A 59-year-old woman presented with stage 3 uterine prolapse. A vaginal hysterectomy and vault suspension. Anterior and posterior vaginal repairs and perineorrhaphy were recommended as the best treatment option. This video will outline the vaginal hysterectomy portion of the procedure. The patient will be placed in the dorsal lithotomy position and given general anesthesia. A Foley catheter will be inserted for bladder drainage, and a self-retaining retractor will be used for exposure. A colpotomy will be performed by making a circumferential incision around the cervix, and the uterus will be carefully dissected away from the bladder and rectum. A hysterectomy is performed by sequential ligation and division of several key structures bilaterally. Clamps on these structures will be placed in close proximity to the cervix and body of uterus to avoid injury to the ureters. The uterosacral ligaments will be clamped, divided, and ligated, followed by clamping, division, and ligation of the cardinal ligaments, and the clamping, transection, and ligation of the uterine arteries. The broad ligament will then be clamped, transected, and ligated bilaterally. The number of bites for broad ligament division will depend on the size of the patient's uterus. The utero-ovarian pedicles will then be clamped, which contain the utero-ovarian ligaments, fallopian tubes, and round ligaments, and the structures transected and ligated bilaterally. The uterus will be removed through the vagina. When performing a hysterectomy procedure for uterine prolapse, a vault suspension, anterior and posterior vaginal repair may be performed. A bilateral sacrospinous ligament suspension is one option for suspending the vault. Following the suspension, the vaginal vault is closed with a continuous running, locking suture. A cystoscopy will be performed at the conclusion of the hysterectomy to inspect the bladder for signs of injury and ensure ureteric patency.